Cardiac chest pain is caused by an inadequate supply of oxygen-rich blood to the heart. This is usually secondary to deterioration of a once stable atherosclerotic plaque. The plaque is the buildup of fat and cholesterol deposits on the walls of the arteries. As the plaque continues to grow, the inflammation can result in plaque instability and rupture. Once the plaque ruptures, the integrity of the artery's inner wall is compromised and platelet aggregation and local vasoconstriction is stimulated. This leads to the occurrence of thrombus formation. The adherence of the thrombus at the unstable lesion may lead to further narrowing or occlusion of the artery. The partial obstruction manifests as unstable angina or non-ST segment elevation myocardial infarction, and total obstruction by a thrombus manifests as ST segment elevation myocardial infarction. The critical level of oxygen-rich blood blockage to the heart is the cause of cardiac chest pain, also known as unstable angina. This occurs with increasing frequency that progresses rapidly, often ending in pain, in chest pain, and easily stimulated by minimal or no exertion during sleep or even at rest. Patients with chronic stable angina may develop unstable angina, or it may be the first clinical sign to detect acute coronary syndrome. Also, a myocardial infarction occurs due to a sustained reduction in blood flow causing irreversible myocardial cell death. The development of thrombus blocks blood flow to cardiac muscle, resulting in necrosis. Risk factors associated with the diagnosis include non-modifiable, which mean they cannot be changed, and modifiable, in which the effect of the factors can be reduced through lifestyle changes. Non-modifiable risk factors include age, gender, ethnicity, family history, and genetics. Also, elevated serum cholesterol, hypertension, tobacco use of one or more packets a day, diabetes, obesity, psychological states, physical inactivity, and substance abuse was positively correlated with an increased incidence of acute coronary syndrome, causing cardiac chest pain. The acute coronary syndrome is commonly seen in patients older in age, with the incidence almost twice as high among men than women in Australia and New Zealand. However, the incidence in men and women equalize after the age of 65, although the mortality rate is still higher among women. Additionally, the acute coronary syndrome is present at higher rates in Indigenous Australians, Maori, Pacific Islanders, and people from the Indian subcontinent in comparison to non-Indigenous Australians and New Zealanders. Genetic predisposition and family history is an important factor in the occurrence of cardiac chest pain. It is estimated that the genetic contribution is as high as 40 to 60%. Most often, patients can name someone in the family who has been diagnosed with heart disease. Hypertension is the second major modifiable risk factor, which is defined as blood pressure greater than 140/90. Elevated blood pressure can lead to the development of atherosclerosis plaque in the walls of the arteries. The formation of the plaque is increased with 2 to 6 times more likely to those who smoke tobacco than those who do not, although the risk is proportional to the number of cigarettes smoked. Additionally, the fourth major risk factor of physical inactivity implies a lack of regular adequate physical exercise. Exercise improves thrombolytic activity, thus reducing the risk of clot formation. The mortality rate from acute coronary syndrome is statistically high in people who are obese. The increased levels of low-density lipoprotein and triglycerides production in obese patients is strongly related to atherosclerosis. Also, obesity is often associated with hypertension, which is considered a second major risk factor. Moreover, incidence of acute coronary syndrome is 2 to 4 times greater among diabetic patients due to the alterations in lipid metabolism and high cholesterol and triglyceride levels. An elevated serum cholesterol level of more than 5.2 mmol per liter or a fasting triglyceride level of more than 3.7 mmol per liter is a major risk factor. The use of drugs like cocaine can produce coronary spasm, resulting in muscle walls to tighten and decrease blood flow to part of the heart. Psychological risk factors include depression and chronic stress. In particular, depression is a risk factor for both the development and worsening of cardiac chest pain. Increased levels of depression are also correlated with higher numbers of heart disease.
Signs and symptoms of acute coronary syndrome can vary depending on the extent and location of coronary obstruction. Clinical signs that could be observed upon examination include abnormal heart sounds and rhythms, such as crackles caused by left ventricular dysfunction, or loud, hollow systolic murmurs, which is an indicator of a septal defect, papillary muscle rupture, or valve dysfunction. Initially, in the early phase of an episode, heart rate and blood pressure are elevated as adrenergic stimulation tries to overcome hypoxia in the heart. However, afterwards, as there is a prolonged reduction in pumping capacity of the heart, a dramatic drop in heart rate and blood pressure will occur, indicating left ventricle ischemic damage. Signs of decreased renal perfusion can also be observed due to reduced cardiac output and hypotension. A reduction in cardiac output leads to a diminished glomerular filtration rate, and consequently, efficient filtration of metabolic waste and fluid regulation is ceased. Additional clinical signs are jugular venous distension, hepatic engorgement, and peripheral edema, which are all a result of right ventricular dysfunction as the heart is unable to adequately pump blood through the body to meet its metabolic needs. The impact of ventricular dysfunction is caused by low cardiac output as blood congestion and poor systemic perfusion occurs. Symptoms of acute coronary syndrome that may be experienced includes angina, also known as chest pain and discomfort. This can be described as a crushing sensation, burning, aching, stabbing, or sharp needle-like pain that may be severe and long-lasting. This pain has the potential to slowly radiate to the back, jaw, shoulders, and arms. Chest pain and discomfort is caused by the reaction of the imbalance of myocardial blood and oxygen supply reaching the heart muscle due to the increase in plaques narrowing the coronary arteries. Dyspnea, also known as shortness of breath, can also occur due to the insufficient cardiac output from the left ventricle resulting in pulmonary edema where there was a buildup of fluid in the lungs. This results in ineffective gas exchange causing an increase in respiratory effort and consequently the feeling of shortness of breath. As a result to pain from cardiac dysfunction of the inferior wall causes the increase in catecholamines from the sympathetic nervous system. Symptoms of nausea, vomiting, and pale diaphoretic skin can then arise. Symptoms of fever are a result of elevated serum levels of myocardial enzymes and C-reactive protein. It is the inflammatory reaction following myocardial necrosis, causing a rise in body temperature and is an indicator of impaired left ventricular systolic function. Due to cardiac dysfunction, symptoms of lightheadedness and dizziness can arise as the heart is unable to adequately supply blood to the brain, meaning insufficient cerebral perfusion and lack of oxygenated blood. In addition, a dramatic drop in blood pressure can also cause lightheadedness and dizziness. The presentation of acute coronary syndrome in certain groups such as women, the elderly, and diabetics may display asymptomatic to angina, where women are more likely to present with atypical symptoms such as dyspnea, nausea, and lightheadedness.
In this slide, I will be going over the diagnostic tests used in ACS. The two main testings used to diagnose ACS are ECG and blood tests. ECGs use 10 electrodes that are attached to the thorax and limbs to detect the electrical activity of the heart. It will show the abnormalities of the heart and the perfusion of blood. A limitation of this diagnostic test is that it does not adequately represent the posterior, lateral, and apical walls of the left ventricle. Also, normal findings does not rule out all ACS. Thus, it is diagnosed with blood tests and the doctor's assessment of patient history, signs, and symptoms. An ST segment elevation that is greater than or equal to 0.1 mV in two or more contiguous leads, subtending the damaged area, is a result of myocardial infarction, and it is called an ST segment elevation myocardial infarction or STEMI. This is a complete obstruction of a coronary artery. Serial ECG testing is done every 8 hours for 1 day and then daily to show that there is a development into a more stable wave or abnormal Q waves, which tend to reinforce the diagnosis. Non-ST segment elevation myocardial infarction or NSTEMI may produce ECG shifts including ST segment depression or T-wave inversion. However, NSTEMI may produce normal sinus rhythms, thus blood is taken to confirm NSTEMI. Similarly to NSTEMI, unstable angina may produce normal sinus rhythm or momentarily have ST segment depression, ST segment elevation, or T-wave inversion. Thus, other diagnostic tools must be used to aid in the diagnosis of unstable angina. The other main diagnostic test is blood tests. The cardiac biomarkers are cardiac troponin, troponin I, and troponin T. These are released into the bloodstream, and high-sensitive assays of cardiac troponin measure the level of troponin T or I. These markers are normally attached to cardiac myocyte and skeletal muscle, but due to myocardial necrosis, they will be detached in more amounts and at different times in the blood, which indicate myocardial infarction. A repeat sample is done hours after initial assessment, as troponin levels are at almost 100% sensitivity. The diagnostic cutoff for troponin T is greater than 14 ng per liter, with a 50% or more grade change in a test done 3 to 6 hours after initial assessment. If there is no or little elevation in troponin levels, but patient is experiencing symptoms of angina, it may be an unstable angina. However, the doctors will make this diagnosis alongside history and other signs and symptoms. Other diagnostic tools used include coronary angiogram, where a radio-opaque contrast medium is injected into a coronary artery, and an X-ray is taken to show the patency of the coronary arteries. Another one is exercise stress test, where a patient exercises and an ECG monitors blood flow and heart function. And echocardiograms, where a transducer uses sound waves to measure the blood flow in the heart, valvular abnormalities, and cardiac function.
Patients experiencing symptoms of an ACS should present to a hospital to receive clinical care, and initial management with patients diagnosed with ACS or coronary symptoms should be given aspirin as a first resource to assist with easing of chest pain, assuming no contradictions are present. Saturation levels should also be assessed as oxygen in an assistance to patients who are experiencing ACS-like symptoms. Secondary JTN should be given by sublingual or intravenous morphine as required. Where appropriate, a 12-lead electrocardiogram or an ECG should be performed, as it is one of two sole tests required to analyze for PQRS T waves or any other abnormalities related to ACS. STEMI management. Patients with STEMI who present within 12 hours of the onset of ischemic symptoms should have a reperfusion strategy implemented promptly. Patients with a suspected ACS without STS segment elevation on ECG should undergo further observation and investigation to rule out other diagnoses, enable risk stratification, and determine the most appropriate treatment strategy. Further to this, all patients undergoing or associated with ST segment elevation myocardial infarction should undergo adjuvant therapy associated with reperfusion therapy for STEMI, as it should also be noted to be administered aspirin and clopidogrel, unless they are contradicted. Antithrombin therapy should be established in combination with PCI or fibrinolytic therapy with fibrin-specific fibrinolytic agents, although antithrombin therapy in conjunction with streptomycin is optional. Non-STEMI management. All patients with non-STEMI ACS should also be given aspirin unless contradicted, whereas high-risk patients with non-STEMI ACS should be initiated with more complex drugs management, including aspirin, clopidogrel, and fraction heparin or subclexine, IV tirofiban or eptifibatide, and V blockers. Intermediate risk patients should undergo an accelerated diagnostic evaluation to clarify whether patients are high or low risk. Low-risk patients should only require observations and assessment, should be discharged on upgraded medical therapy for follow-ups. Long-term management and post-control of myocardial ischemia. Pre-discharge patients with diagnosis of ACS are initiated on a regular drug regime, which includes orally taking medications such as antiplatelet agents, B blockers, angiotensin-converting enzyme inhibitors, statin, and other therapies as appropriate. They are provided with access to and actively referred to comprehensive ongoing prevention and cardiac rehabilitation services. The following may be prescribed for the treatment of ACS. Thrombolytics contribute to dissolving blood clots obstructing an artery. Nitroglycerin enhances blood flow by temporarily widening blood vessels. For STEMI, 0.4 milligrams sublingually are administered every 5 minutes or up to 3 doses as blood pressure allows, or 10 micrograms per minute via IV. For non-STEMI ACS, as prescribed for STEMI, although should not be prescribed if a type 5 inhibitor has been received within the previous 24 to 48 hours. Further, IV prescription can be used for persistent ischemia, heart failure, or hypertension. Antiplatelet drugs prevents the formation of blood clots and includes aspirin, Plavix, Effient, and Brilinta. For instance, the use of aspirin follows. For STEMI, if used with PCI or fibrinolytic therapy, an initial loading dose of 102 to 305 milligrams, and the maintenance dosage of 81 to 305 milligrams per day indefinitely after therapy. For non-STEMI ACS, an initial loading dose of 152 to 305 milligrams and the maintenance dosage of 81 to 305 milligrams per day. Beta blockers aids with heart muscle relaxation to reduce heart rate by decreasing the demand on the heart while lowering blood pressure, although a contradiction where signs of heart failure, low output state, and risk of cardiogenic shock are present. For STEMI, oral Coric prescribes 6.25 milligrams twice daily, titrate up to 25 milligrams or 5 milligrams every 5 minutes as tolerated, up to 3 doses. For IV metoprolol, or 25 to 50 milligrams every 6 to 12 hours, eventually transitioning to twice daily for oral metoprolol. Non-STEMI ACS, as prescribed for STEMI with contradictions upheld. Angiotensin converting enzyme, ACE inhibitors, stimulate heart performance by widening blood vessels for improved blood flow. For STEMI, captopril may be prescribed 6.25 to 12.5 milligrams TDS, titrate up to 25 to 50 milligrams, or lisinopril 2.5 to 5 milligrams per day, titrate up to 10 milligrams. For non-STEMI ACS, as prescribed for STEMI, granted left ventricular injection fraction less than 40% hypertension, diabetes mellitus, or chronic kidney disease. Angiotensin receptor blockers assist with blood pressure control and involves Vapro and Cozar. For STEMI, Diovan may be prescribed 20 mg twice daily, titrate up to 165 mg twice daily. For non-STEMI ACS, an alternative for patients unable to tolerate angiotensin converting enzyme inhibitors. Statins reduce the level of cholesterol movement in the blood, which aids with plaque deposit stabilization as reduces the likelihood of ruptures. Examples include Lipitor and Zocor. Oxygen. Patients presented with acute chest pain and presumed ACS do not require oxygen without the presence of hypoxia or heart failure. Glycoprotein inhibitors. Consider when the patient is presented with an intermediate or high cardiovascular mortality risk or due to undergo PCI within 72 to 96 hours, or patients who have had PCI with difficult lesions in the coronary arteries. Sublingual or GTN promotes vasodilatation or dilatation of the coronary arteries and can be used in scenarios involving ischemic chest pain, though systolic blood pressure must be less than 90 milligrams of mercury.
In this slide, I will be talking about the short-term and long-term complications of ACS. Arrhythmia is caused by cardiac ischemia that alters nerve impulse sensitivity in the myocardial cells. This includes atrial or ventricular fibrillation and AV block causing bradycardia. Reduced blood flow to sinus nodes causes sinus node disturbances which result in bradycardia or tachycardia. Myocardial ruptures are serious complications of infarction. Ventricular septum rupture leads to blood flowing back into the right atrium, and that results in right-sided heart failure. A rupture of the left ventricular wall leads to blood pooling into the pericardial sac, which leads to cardiac tamponade, which is a fluid accumulation in the pericardial sac that compresses the heart. This leads to a decreased cardiac output and shock, and may result in cardiac arrest. A rupture of the papillary muscle will lead to mitral valve malfunction and regurgitation. This will result in pulmonary edema. Heart failure is another complication where myocardial necrosis causes the cardiac muscles to become weak and stiff. Thus, the heart cannot keep up with the body's demand for oxygenated blood, resulting in left ventricular failure and cardiogenic shock. Pericarditis is another complication, which is the inflammation of the parietal pericardium, which causes cardiac compression, decreased ventricular flow, and heart failure. This typically occurs 2 to 3 days post-MI. Mural thrombosis is the development of a thrombus in the apex of the left ventricle. This is caused by cardiac endothelial injury and turbulent blood flow and states of hypercoagulability. This can then lead to an embolism when the thrombus detaches from the vessel wall. This can lead to strokes, DVTs, and other thromboembolisms. Long-term complications of ACS is post-MI syndrome or Dressler syndrome. This is where pericarditis is accompanied with fever and effusions, and this typically develops 4 to 6 weeks post-MI.